head of the radiology department in the Maadi Armed Forces Hospital. He's also the Secretary General of the Egyptian Society of Radiology and Nuclear Medicine, and he is the head of the Egyptian Society of Radiation Safety and Quality. Prof. Hany, the floor is yours.
Thank you, Firs. Clinical image guidelines are regulations imposing responsibilities of imaging departments to ensure that all exposure to ionizing radiation are justified and that the doses are optimized. The guidelines have been designed as assimilate, evaluate, and implement the ever-increasing amount of evidence and opinion on current best practice. The primary and second, third, fourth aim of clinical imaging guidelines is the practice. It's the first and the most important item. After that, we will shift to exposure, radiation exposure, and consumables and other things. In any item of our life, it is important to weigh the benefit of the exam against the potential risk of performing the test. The causes for an inappropriate referral, doing the wrong investigation or the not best investigation or modality or technique, failing to provide appropriate clinical information, repeating investigation which have already been done. Investigation is too often. Investigation which when results are unlikely to affect patient management or not indicated initially. Improper and wrong preliminary diagnosis or interpretation of examination. That is the table which are working in our departments. We'll give some examples for each item. Not the best imaging modality. As we see, cellular examination, some clinicians ask for CT cellular, others ask for MR brain, but the real and the proper investigation is dynamic MRI of the cellular. That's the table. As we see, here is CT scanning. It is so difficult to define pituitary microadenoma by CT scanning, also in sagittal scanning, but in MRI dynamic, it is the focus which is less enhanced. Also, for macroadenoma, CT scanning not show the extent of the lesion, which is seen encroaching upon supracellular cistern and optic chiasm. Acute abdominal pain, the first imaging modality is ultrasound. That's wrong to ask for CT abdomen from the start. Also in children, it is preferable to make MRI, to perform MRI. That's plain film, appendiculus, thickening of the wall of the appendix, but it needs some expert. That is CT scanning to confirm the diagnosis. In children, we shift to MRI. In ureteric colic or suspected colic, it differs from abdominal pain or acute abdominal pain. In suspected ureteric colic, we shift directly to non-contrast CT study. The first imaging modality in thyroid is not, of course, is not the MRI. It is the ultrasound and Doppler, and after that we could shift to isotope scanning. That's ultrasound, which is very accurate in assessing cystic and solid lesions of the thyroid gland. That is isotope scanning. For young female, the first imaging modality is breast ultrasound and not the mammography. In dense breasts, as we see, it is difficult or harder to see the focal lesion, but in ultrasound it is very easy to get that lesion. That is also a referring physician. May he think that dynamic study is a spiral study. The thing is here is he write by Arabic, non-contrast. Although dynamic study means that it is a contrast study, but he think that dynamic study is a spiral study or something like that. For suspected female pelvic lesions, the first imaging modality is ultrasound. Next imaging modality, if we see complex cysts or tumors, it will be MRI study. CT is not accurate in female or male pelvis because of the ill definition of soft tissue textures and differentiation of densities. In stroke, CT is the first imaging modality to detect hemorrhage or no hemorrhage. If there is no hemorrhage and we are suspicious for stroke, we shift to MRI diffusion study, which is accurate. That's the case with nothing in CT scanning and the restricted diffusion in MRI study. Emphysema will not shift to contrast study of the chest. It's only we ask for non-contrast study of the chest. As it is parenchymatous disease, no suspicion of mediastinal lesion or vascular lesions. Unnecessary repeat. Sometimes doctor lacks the knowledge, so ask for repetition of examination. Also, he is confident only in his hospital. No other hospitals will be applicable for him. Also, the problem in some countries is fee splitting. Fee splitting is giving the referral physician money to send patient to the radiology center or the hospital to give him some money to send that. That is all illegal and ethical issue. That's a surprise. That's old image. Patient come with a swelling of the abdomen, and the hair doctor ask for CT scanning from the start. We see here the bones of a baby. So the first imaging modality in any female, whether married or not married, is ultrasound. Investigation is too often. We see our radiographers frequently go to the ICU unit, maybe every 2 hours, to follow up effusion or pneumonia. That's not correct. This is very often. Improper and wrong preliminary diagnosis, that's lesion here in the right lung base. The clinician thinks that is pneumonia and don't respond to our request to make CT scanning. So the patient is delayed to make CT scanning 2 months later. 2 months later, it is chondrosarcoma of the rib. The challenges against CIG implementation is unawareness of physician, radiologists, radiographers, congestion in clinics, so referral physician ask for radiation procedure, for lab procedure, ECG, patient pressure to perform the investigation, uneven distribution of machines, fee splitting, which is illegal and unethical, self-referral, that referring physician has his own CT scanning or X-ray machine. Our recommendations that don't hesitate to discuss the best imaging modality with the radiologist. Radiologist is a double-edged sword. Mistakes to lead to consumer abuse, radiation exposure, false or delayed diagnosis, thus improper treatment, increased morbidity and mortality. Referring physician should give the radiologist the patient data, previous examination, awareness by imaging modalities and ethical concern, choice of good radiologists and departments, communication with radiologists. On the other hand, radiologists should choose the best imaging modality, manage technique, communication with patient and referring physician, careful interpretation, and proper reporting. So you will get the best benefit from imaging. Thank you.